Okay, so now we're on to chapter 33, which follows chapter 36, where we talked about the immune system, immunology, and immunodeficiencies. The next thing I wanted to talk about is HIV and AIDS. HIV is the human immunodeficiency virus, which can lead to AIDS. So there's really, once a person acquires HIV, the virus, it does not necessarily mean that they also have AIDS, and we're going to talk about that, but it's really important that you understand that this is a human immunodeficiency virus. This is a virus that can be obtained in the body that can lead to one of the immunodeficiencies that I was talking about. This virus in particular is extremely complicated and rather deadly. So what we do as nurses is prevent. This disease came out in the early to mid 80s, like back in 1983. So prior to that time, we didn't know a lot about it, and when it was first identified, the HIV virus, we did not have a lot of ways to treat it. That has since changed. There's a lot of ways to treat it now. People are not dying nearly at the rates that they used to be. However, HIV remains a humongous global problem. We've got it fairly well contained within the United States, but if you go outside the United States, especially into the third world or the developing countries, it remains a ginormous problem, which really requires a lot of nursing intervention. So if you're interested in missions work, working on mercy ships, or in some of these developing countries, you're going to encounter HIV and AIDS quite a bit. So the first thing that you need to know about it is how is this virus transmitted? It's really not that easy to get. You can't obtain it through urine or by kissing. It's not transmitted through saliva, but it is transmitted through blood and semen, and it is transmitted from mothers to babies, especially when the baby is being delivered vaginally. So sometimes if they have identified that the mother has HIV, if they're able to take the baby C-section, sometimes then the baby can be spared from the virus. And they're doing some treatment now with infants of mothers who have had HIV with some success, but there's still some work being done with that. But what you're seeing in some of these developing countries is these babies are being born to mothers with HIV, and then the babies are being born with it and very quickly developing AIDS, and the life expectancy then becomes very short. So as nurses, we want to, one, prevent it. So this becomes a big public education thing. We need to educate the public on how it's transmitted, and that's blood and semen. So obviously IV needle drug sharing is a risk factor. Homosexual intercourse, especially promiscuous or unprotected sexual intercourse, especially among male homosexuals, because penis to anal penetration can often tear the colon, and then you get the semen-blood interaction or mixing. So you see it much more often in promiscuous homosexual males. Monogamous homosexual males tend to practice safer sex, and so it's not as prevalent in that. In the prostitute community, where people are not practicing safe sex, that can also be transmitted that way, especially if there's any open sores and there's a bleeding mixed among the semen. That's how it can also be transmitted. So it's not the easiest thing in the world, but definitely it's considered one of those high-risk behavior complications that you can get. So again, we need to just educate the public on safe sex, safe needles, if they're unable to, to stop needles, stop IV drug abuse, things like that. So we want to try to prevent that. Okay, so I already went over that. So then the pathophysiology of HIV, it's fairly complicated, and you don't need to know all of the intricate details of the pathophysiology of the HIV, but this part you kind of need to know. The big problem with, sorry about that. The big problem with HIV is these CD4 counts. and its ability to bind to those CD4s. Remember on that last video that I showed you when I was showing you the antigen antibody and how the T cells bind into the antibody sites? This is what's going on here. I'm going to show you another picture of kind of what this looks like. Whoops, I already did that one. Okay, so this is what it looks like, and I know this is a little bit complicated, but this is the cell here. These are the CD4 receptors up here. These are the CXCR4 receptors here. And what happens with this HIV virus, the virus then can penetrate into the cell. And you know, remember in that other video that I was showing you how the macrophages come in and can like attack a virus and sort of engulf the virus inside the cell? Well, what happens in HIV is this virus is actually able to get into the cell and then replicate itself. So what happens is the virus comes in and comes into as an RNA and attaches then to the single-strand DNA, and then as that single-strand DNA starts moving into that helix, the double-stranded DNA, you know, like in the genome, your genetic component. And then it actually, what happens is it mixes in with the human DNA. You've got the splice in of the viral DNA. This is the infected part now. And now what you've got is this virus that is able to replicate itself inside the cell. And then what it does is it comes back out and it releases itself, and then it starts budding to create more virus, more infected virus. And so what happens is it really gets into these cells and almost mutates and kind of takes over. That's it in a nutshell. It's more complicated than that, but from your standpoint, that's what is going on. So it affects the RNA in the single-stranded DNA and going down into this genomic double helix, the human DNA, and then replicates itself. And this is really where the problem comes in. So as the RNA moves into the DNA, becomes replicating itself, then what happens is it will start to take over the entire body. And it will, you really need, as a nurse, this is the important part, you need to watch these CD4 counts. The CD4 are this very particular component of the T cells. The body's ability to manage the virus is pretty good if you can keep those T cells high. Once these T cells, and by high I mean like you want to keep them greater than, the older studies used to say 200. I think that your book says you want to keep them above 350. But normal is upwards of 800, like 800 to 1200 is normal. So that's what you want to do, because when those CD4 counts start going down, then you're going to start your patient's going to start developing some immunodeficiencies and compromise. And you're going to really start seeing some problems when those counts get down below 500. Not necessarily AIDS, you still haven't gotten AIDS, but what I mean by problems is the patient will start developing opportunistic infections. Infections that will pop up because the body's immune system is compromised, the immune system is weakened. So these other viruses and problems that typically the patient can ward off, they're not able to ward them off as much as they used to. And so what happens when a person is first infected with HIV, and often when they're first infected, they don't even know it. But you get the HIV infection, and usually there's a tiny little dip in these CD4 counts. Most of the time people don't even know it. If you'll remember, a high percentage of people that are contracting the virus don't tend to have healthy lifestyle habits. They're not running to their physician's office all the time. They're not eating healthy. Oftentimes their living situations are less than ideal. Not always, but there's a high component of that. So they don't even know that they might have a little cold or just have a little bit of general malaise, maybe a tiny fever. They blow it off, don't even know it. Unfortunately, during this phase, they can infect other people because they have the virus And this component, this right here, is the antibody. So here comes the viral load right in here. This is when they're getting infected with the virus. And then the body is recognizing, oh, here's a virus, and it will start developing HIV-specific antibodies. Remember how I showed you the antigen-antibody interaction from our last lecture? Well, so the body will try to start developing some antibodies up here. And so, and this can take months. And then your goal as a nurse, one is to identify that the patient is actually carrying HIV virus, and then teach the patient that they have it, and then try to get them to, one, stop the lifestyle or whatever caused it, and then support them. Your fluids, rest, good nutrition, low stress, all these kind of things. And we do have some really good antiviral drugs now. It's complicated. It's a complicated combination of therapies, but if you can get your patient to improve lifestyle, eat healthy, and then manage this, the viral pharmaceutical concoction, the patient can hopefully live for years and years and years and years. Until, like you can say, they can live for a long time. And your goal is to keep them right here. You can't eradicate this virus. We have no known cure, but we can treat it. So you want to keep your patient as healthy as possible because you want to prevent the development of AIDS. And AIDS stands for acquired immune deficiency syndrome. So that's what we're really trying to prevent. So if the patient is untreated, and this is what you'll see much more in some of the developing countries where they don't have the medical interventions that we have here. So oftentimes people who are in the developing countries don't survive very long with this virus. Because they're also dealing with things like unclean water, insufficient amounts of medicine. Many of the children are orphaned by parents who had died of AIDS, so now the children are trying to take care of children. So the early chronic infection can occur for, 6, 7, 8 years. If it goes untreated, then these intermediate chronic infections start occurring. So these are things like, like the patient might have more general malaise, urinary tract infections, pneumonias, things like that can start occurring. And then in the late chronic infection is when the opportunistic diseases start taking over, and then the patient gets AIDS. And I'm going to show you what some of those opportunistic infections actually are. So AIDS really isn't, sorry, my dogs are annoying, I don't know what they're barking about. Now I can't remember what I was going to say. We'll go over. All right, so let's do this question. This would be like an NCLEX kind of question. So the question is, you have a diagnosis of AIDS can be made for a patient with HIV when there is what? So your choices are, you can diagnose somebody, so you know the patient has AIDS. The question is, you can diagnose them when? When your CD4 count is less than 500. Well, I just told you that's not ideal when it's less than 500. Your white blood cell count is less than 3,000. Again, not ideal. If you remember, normal white blood cell counts are 4,000 to 10,000. So this is getting a little low. The development of oral candidiasis or thrush. This is also not ideal. But your patients who are, their CD4 counts are dropping and their white blood cell counts are dropping, this is going to reduce the ability to fight the normal flora in the mouth, so the patient is going to be at higher risk for thrush. So you might see thrush when your CD4 counts get below 500 or your white blood cells counts start dropping. You could see the development of thrush. However, none of these things are indicative of AIDS. What is indicative of AIDS is when you start seeing the onset of some of these opportunistic infections that you would not normally see unless the patient has this, human immunodeficiency virus. And that is the onset of things like pneumocystitis jirovecii pneumonia, also called PCP pneumonia. Patients, this is a very specific kind of pneumonia. This pneumocystitis jirovecii will only show up in the presence of HIV, and then you know the HIV virus is taking over, developing AIDS. There are a couple, so number 4 is your answer. These are certainly all components of a patient who has HIV, but it's not, you can't diagnose it as AIDS until they start developing one or more of these opportunistic infections, and these will start occurring when your CD4 counts get very low. Like some studies will say less than 350, and other ones say it'll get as low as 200, but they're for sure less than 500. So that's when you'll see some of these opportunistic infections starting. So in the early stages of the acute infection, like I was saying earlier, the patient might just have something like flu-like symptoms, like general malaise, fatigue, rash, thrush, and this usually is occurring about 1 to 3 weeks after they have been infected with the virus. So they might not even make the association that they have been infected with the virus. Then when this early chronic infection begins, and like I showed you earlier, that can be like a year to 8 years out. They may have some of these low-grade fevers, some night sweats at night, but many of them have no symptoms whatsoever. They have no idea they're carrying the virus, and hence they continue to spread the virus. In the intermediate chronic phase, this is when we're starting to have some problems. Like if you go back to that other slide where you see the stair steps down, you'll see that these CD4 cell counts are really starting to drop low. The viral load is then starting to get high. So that's when you'll see that the crossover occurring. That's when we're starting to run into some problems. And the virus itself is starting to get into more advanced stages, and you'll see some of these symptoms occurring. Oral hairy leukopenia. Leukoplakia is white spots in the mouth, so they'll start kind of getting like not quite thrush. Thrush is like a fungusy substance, yellow substance in the mouth. Oral hairy leukopenia is like hairy thrush kind of in the mouth. I might have a picture of it. Really tired constantly, drenching night sweats. So all of these symptoms are just getting manifested and more significant than they were in early. Oh yeah, I have a picture. This is oral hairy leukopenia. So it looks a little bit like thrush, but you can see how it's just kind of got some like hairy components to it. And you'll notice most of these people, like I was saying earlier, they have some other issues. Like you can tell these people don't have good dentation. They probably have not been getting good oral care, things like that. They're also going to contribute to this virus expediting itself a lot faster. And then again, when it goes into the chronic late stages or actually developing into AIDS, you can diagnose it with AIDS when some of these opportunistic infections start occurring. And they are at risk for specific kinds of malignancies like Kaposi sarcoma. I'm going to show you what that looks like. Most of the time you don't get Kaposi sarcoma unless there's in the presence of HIV, at which time you can diagnose this patient with AIDS. The immune system is extremely compromised. They can start developing HIV encephalopathies where they get confused. There's a lot of muscle wasting. I think I've got some pictures too. And again, once you see the development of these opportunistic diseases is when you can diagnose that the HIV has now become AIDS, or really HIV has now caused AIDS. They're two separate things. But any of these can occur. And I'll show you what some of them look like. This is PCP pneumonia, cryptococcal meningitis, CMV retinitis, that's CMV and the retina, MBA complex Kaposi sarcoma. They get the influenza, which is like, regular influenza, like bad flu, but they have the bad flu that just does not go away. So this is what it looks like. The jirovecii, pneumocystitis jirovecii pneumonia, PCP, it's a very unique, they would get a biopsy of the lung and put it under a microscope and stain it, and the pathologist can tell that it is pneumocystitis jirovecii pneumonia, and it ends up looking like this on an x-ray. It's kind of got like this scattered sort of cotton candy look to it. So this is a PCP This is the pathology slide of it, and this is the radiology slide of PCP pneumonia in the presence of somebody who has AIDS. This is an example of Kaposi's sarcoma. This is a malignancy caused by the HIV, and now the person has AIDS, but you can see right here the patient has a Kaposi's sarcoma, and also here, see these red blotches? That is the Kaposi's sarcoma. And then down here, these are examples of late stage AIDS patient. You can see extreme muscle wasting. This is a full-grown man, and he's just very emaciated. He's just covered with Kaposi's sarcoma, and you can just see the extreme wasting, the jaundice. He's confused, probably has some encephalopathies going on from it. It's just an absolutely devastating disease. It's very difficult to treat. The other problem with the treatment, the pharmaceutical regimen, is complicated. You have to take several medications throughout the day, and it's a very strict regimen. So if somebody is also an alcoholic or has insufficient access to health care, they're unable to get the kind of treatment that's necessary to combat this disease. So unfortunately, it's difficult to treat. So like I said earlier, this is just a recap. In order to diagnose somebody with AIDS, they have to meet the CDC criteria for AIDS. I'm going to show you that in a second. CD4 count needs to be below 200 to 350. You'll see those in different spots. They must have an opportunistic infection going on, usually have a wasting syndrome, and then they get the AIDS dementia complex. So that's really the outline of AIDS. And I wanted to show you, if you want to, this website, the Center for Disease Control and Prevention, that's got very up-to-date information on it relating to HIV. So it's cdc.gov/HIV, and you will get all this information in there about what are the basics of it, risks and prevention, how do you get testing, what are the statistics for it. So if you're interested in this, because there's a lot more work that needs to be done, and it is such a global problem, we do need more nurses working on this and taking care of patients and helping to prevent this disease from occurring. So there you go. That's HIV and AIDS in a nutshell. And then next time we will do some allergy stuff. Okay.